Hello, everyone. Welcome back to our second part of Claudia Brown's presentation about biofeedback and its use in pelvic health for physical therapists and pelvic floor specialists. We're very happy to have you here with us today once again. And without further ado, I will let Claudia begin. Hi, Claudia. Thank you for being with us.
Hi, Gala. Thanks very much again for inviting me to do this webinar. So I'm happy to be here for the second part. I hope that the first part for all of you that did attend was helpful. So what we're doing in the second part, and let me just see, change my slides here. Okay, so part two. Okay, so in part one, what you saw was the nature of biofeedback, why it's particularly useful with pelvic floor training. You saw some of the technical considerations that we have to take into consideration. And we talked a little bit about biofeedback applications in evaluation, education, training, and exercise prescription for the pelvic floor. For this part, we'll be illustrating these concepts with two case histories. So one case history is somebody who has a weak, hypotonic, underactive pelvic floor, and the other case history is somebody who has a hypertonic, overactive pelvic floor. And it doesn't necessarily mean it's strong. When it's overactive, sometimes it's actually weak because the muscle is too busy with its tension to be able to actually work functionally. So an overactive pelvic floor is often actually weak as well because it can't contract and relax properly. So those are the two cases that we'll be showing you. Okay, so yeah, so we're going to use these two case histories to illustrate the concepts that we discussed in the last webinar. And I'd like to really have you understand like the difference between using EMG biofeedback when you're actually training somebody to become stronger and use their pelvic floor more, and also somebody who has to really just relax and get the pelvic floor musculature to stop being overactive so that it will work more functionally. And hopefully with this illustration, you'll be able to, on your own, set up a biofeedback training program for your patients. So in pelvic health, biofeedback, we use it for people of all genders and most ages. I mean, I've used biofeedback actually for somebody as young as 4 years old because this little girl was particularly in tune with what was going on. But usually I don't usually start biofeedback until maybe about 7 or 8 years old. But, it all depends really on the child and their maturation and development. And you can use them, right until the elderly. The reason it's so good, again, is because the pelvic floor is kind of hidden. So people don't know when they're contracting, when they're relaxing, unless they're looking with a mirror. And even in that case, sometimes they can't see. So really, by being able to visualize this muscle that's hidden, it really makes biofeedback a perfect adjunct to your treatment. Your patient has to be able to understand what's going on. They have to have really a certain amount of cognitive ability to really understand that what they're doing is actually affecting the screen, and being able to concentrate on that, and also having the motivation to work with this. They might understand what's going on, but it just might not be motivating for them. So it has to be somebody who is really interested in learning and interested in participating in the treatment. We use it for urinary dysfunction, anorectal dysfunction, sexual dysfunction. So anything where we have to have the patient learn how to control the muscle. In terms of contraindications, there really aren't any that I can think of except for allergy to nickel, because the probe sometimes said the metal part might have nickel on it. So that might be the case. Or if the patient has I should have put that down though, you might want to write that down, an active urinary tract infection. Sometimes by contracting against the probe can cause compression on the urethra, and if the urethra is already inflamed, then it can increase the symptomatology. So active urinary tract infection, I would not use an intracavity probe. If the patient has a pacemaker, then that might distort your signal. So these are things to take into consideration. So you cannot harm the patient who has a pacemaker by using biofeedback, but the pacemaker might give you abnormal results. So we'll dive in right away with the first case history. It's a 52-year-old woman who's a secretary. She's complaining of stress urinary incontinence, and she's begun to make adaptive changes to her physical activities. Like she was really loved to run, and she decided that she wouldn't be running anymore. She's doing something else. So she took up yoga instead of running, and for cardiovascular, she decided to do some spinning. And so she had to change her physical activities because she was leaking during her sport. And then she started to go to the washroom just in case before she'd go out for a run or before she'd go to any class or before she go to her yoga class when she stopped running. So she sort of changed or adapted her habits to get around the problem. And she was also wearing protective padding. And at first she was only wearing the padding during her sport activity, but when she actually came into physiotherapy, she was actually wearing it every day. So she was wearing just panty liners, but she was wearing about 3 panty liners every day. And so this was a problem. So upon physical examination, I verified, and she had a decreased muscle tone and a very weak pelvic floor contraction. So as physiotherapists, you would know the difference between the two. If you're not a physiotherapist, it might not be as clear, but muscle tone is really what the muscle is like at rest. And so if the muscle tone is decreased, then the muscle is a lot softer and it's a lot less ready for immediate activity. Muscle tone is also correlated to prolapse. So often if a patient has prolapse of the internal organs, you'll find that they also have decreased muscle tone. So muscle tone is really a test of how the muscle is at rest. Is it soft? Is it hard? What is its resistance to passive stretch? So that's muscle tone. So hers was down. She also had a very weak pelvic floor contraction. And she had what we call the inversion of the perineal command. And this was sort of sporadic. So every once in a while, she was able to generate a contraction, but other times she would actually push instead of contract. So she really wasn't doing very well. And her contraction was so weak that you almost had to imagine the contraction when we did the palpation. So it was an internal palpation to feel that there was a certain contractility, but it was very, very weak. And it was not constant because a lot of the time she was pushing instead of contracting. She also had a grade 1 cystocele, so her bladder was distended slightly. And I noticed as well that she had decreased abdominal muscle strength and recruitment. And this is actually quite important because the abdominal muscles work in synergy with the pelvic floor muscles. And you need a good abdominal strength to be able to generate your pressures in sort of like the right direction. When you cough, if you have good abdominal strength, then the resultant pressure from the cough might be pushed more posterior and less anterior over the bladder. So this is something in terms of in physio we look at their whole posture and biomechanics as well, and not just the pelvic floor when we're doing their training. So my treatment goals for her were to decrease her stress, urinary incontinence, improve her micturition habits, improve participation and her quality of life. I wanted to improve also her muscle proprioception and contractility, meaning I wanted to be sure that when she did her contraction, she was doing it correctly and that she felt that she was doing the activity correctly. In terms of contractility, there's a lot of different things that I want to work on. I want to work on her ability to contract, but I also want to work on her strength. I want to work on her endurance, and I want to work on her recruitment speed. So in terms of contractility, it's not just a matter of can she contract or not, it's can she contract? Can she feel that she's contracting? Can she contract strongly? Can she contract quickly? Can she contract for a long period of time? Eventually, too, I would like to improve the pelvic floor muscle tone, which is something that takes a lot longer to train than muscle contractility. And then improve her abdominal muscle recruitment and strength, and hopefully decrease the usage of pads. So in her first treatment, I mean, since she's not contracting hardly at all, and she's also pushing half the time, I don't want to use biofeedback right away, because if I use biofeedback, what's going to happen is that she'll try by every means to lift that line, and she might succeed by contracting her glutes or by over-contracting her abdominals or her adductors. So for the first couple of treatments, I want to make sure that when I'm putting her on the biofeedback, that she's contracting the correct muscle and she's not getting false positives. So in order to improve her contractility, we have a lot of other things that we would do. So educating her on what the muscle looks like, showing her the pelvis and showing her, explaining to her why it's important to contract the muscle. And then we use manual techniques as well, which are internal and external techniques that will facilitate the muscle contraction by increasing proprioception. Also, sometimes we can even do a slight resistance, because when a muscle has a bit of resistance, it might try even harder. So we have a lot of different techniques that we can do manually to make her more aware of the contraction and to make sure she's contracting properly. So also what really helps is electrical stimulation. So I would use the same probe that I use for biofeedback, and I use this type of waveform in order to get a safe and comfortable contraction of the pelvic floor musculature. So the electrical current will cause the muscle to contract. So even if the patient doesn't even try to contract, my probe will make her contract. So she can feel that sensation of what a contraction actually feels like. So it's very proprioceptive. So I always often will explain to her, it's like when you're playing tennis and you try to hit the ball, but if somebody comes around and takes your arms and hits the ball with you and for you, you understand the movement a lot more. So this is sort of like what the electrical stimulation does. It imitates, it does the movement, imitates it so that you know what you have to do afterwards. So I find for patients who are really low on the contraction scale, I'll use electrical stimulation. And then I'll give her an exercise program adapted to what she's able to do. So this will be for the first couple of treatments. And, you know, hopefully by then, after 2 treatments, I'll be able to put her on the biofeedback. So the third treatment, I'll be doing education manual techniques and electrical stimulation as well, but then I'll also be doing the biofeedback. So this is where we'll do a bit of a demo, and I'll let you know for say the third treatment. And this is, you know, obviously not a recipe. It's just an example of what you can do when you're treating your patient. So you'll always adapt according to, you know, availability of your equipment, you know, how motivated she is and how well she's doing on her program. So Geva, if you would like to show us a bar graph, this is a good one to start with for somebody who really doesn't know how she's contracting. So I guess you'll have to share your screen. So at this point, like I say, while we're waiting for Geva to get this ready, at this point, she's able to contract. She's not great at it because we've only done a couple of treatments, but she's really getting the idea. So I think now is a good time to show her what she's able to do on the screen. Okay, so we have channel A on the, channel A is on your left.
Yes.
Okay, and channel B is on your right. Okay, so let's pretend that, okay, that the channel A is the pelvic floor. And I've put channel B on the abdominal muscles because very, very often when they try too hard to contract, they'll overuse the abdominals. I mentioned before the abdominals are synergistic with the pelvic floor, so we know there will be some abdominal work. That's normal, but we don't want her to overuse the abdominals, and that's what happens with the inversion of the perineal command, is that instead of using the pelvic floor, they push with the abdominals. So let's just say, can you make it so that you don't see the abdominals and you can just see one? Does that work?
Yep, absolutely.
Okay, so I don't want to you know, distract her with the abdominal work right away. So what I'd like to do is I'd like to have you, okay, so let's say you're able to squeeze, and so she's trying to squeeze. Okay, try a little bit more. Okay, that's great, and hold it and release. And so she'll be able to see that, and as she's doing better, I can increase that goal line. So say she starts right now, okay, do a contraction of the pelvic floor. So your command is, you know, pull in the skin, squeeze your muscle. Imagine you're trying to hold in gas. Like, there's different commands that will help. And sometimes I'll actually even do a manual technique at the same time. So say I have the probe in there. So it's backwards for me, so it's a bit, okay. So I might just, if the probe's inside, I might just have my finger right here and say, okay, squeeze, squeeze. And just by having a little bit of a tapping, she remembers that we did that during the first treatment. And so she's able to recruit. So, okay, squeeze there. Go ahead, squeeze. Squeeze, squeeze, good, and let go. And so by giving different commands and the same ones that you did in the first treatments, then she's able to hook in on that and see that she can actually lift that line. Okay, so once she's good at that, then I can increase the threshold and say, okay, try a little bit harder. See if you can squeeze a little bit more. And so I can bring the threshold up. Okay, and so squeeze up until there and squeeze and hold. Let's hold it for 5 seconds. Can you touch it for 5 seconds? Good, 1. Keep on holding over 2. Keep on holding 3. Good, 4. And 5. Excellent. Okay, and back down. Okay, so she's doing that, but I'm noticing that sometimes still she's doing a bit of an inversion. And the way I can tell that is that my probe starts to slip out a little bit. So if the probe is slipping out, I know she's working the abdominals more than she's working the pelvic floor because there's a pressure gradient going in the wrong direction. So I'm realizing that she is doing it, but she is still overworking the abdominals. So now I put on the abdominal cable. Now that she knows, okay, the gray cable is her pelvic floor, so you can put the abdominal cable on. Okay, and now I'd like you to squeeze and squeeze the pelvic floor. Okay, and you can see your abdominals are working a little bit too hard. So what I'd like you to do in that case, when I see the abdominals come in, then I bring the threshold down on the pelvic floor. And I say, okay, don't try so hard. I want you to squeeze only up to this threshold. Okay, good. Just a little tiny little squeeze. And when she does that, her abdominals won't kick in as much. So she can realize that, okay, if I try too hard, it's really my abdominals that are working too much. So it's one way of teaching her how to, yes, we know there's some abdominal work, but we don't want it to be excessive because you'll try a little bit less. And then when she's able to do that and still keep her abdominal trace down, then I'll increase the threshold of the pelvic floor again. Okay, now do a little bit more, but remember, you're only squeezing the pelvic floor. Don't squeeze the abdominals. And then that way she'll be able to really learn the difference between the two activities. Okay, so that might be what I would do, say, on the third treatment. And then when I get to the fourth treatment, and she's starting to get better, she's doing her exercises, the manual techniques have worked. I'm still doing a little bit of electrical stimulation because it's waking up the muscle. But now we can get into some more advanced training. So if, Gav, if you can put it on like a double line graph, that would be good. Okay, perfect. Okay, is that one on a 510?
Yeah, already set to 510. 5 seconds work, 10 seconds rest.
Okay.
Would you like me to start a session?
Yeah, we can start the session. And if you look at when we start the session, you'll see the work rest. So work. So squeeze the pelvic floor. Squeeze both actually for 4 seconds. Okay. Oh, and I'm going to rest. This is the 10 rest section. Okay. So here at this point, we see that she's still contracting her abdominals too much. But it could also be, and maybe you can just pause for a second.
Yeah.
What often happens too is that the abdominals are showing up too much. Not necessarily because she's over contracting, but because the abdominal cable or the abdominal channel is too sensitive. Okay. If she's doing a contraction and I find that the probe isn't slipping out, then it's even the abdominal work she has is okay. But as soon as she contracts and the probe starts to slip out, then I know she's really overworking her abdominals. So that's sort of a way to be able to tell. So in that case, what I would do is I would change the scale on the abdominals and make the abdominals show up less so that we can still keep our eye on them, but they won't be so important. Okay, great. Okay, so now she can concentrate on her pelvic floor without thinking, oh my gosh, the abdominals are going too much. I'll keep my eye on the abdominals. And as soon as I'm sort of holding the probe at the same time. And as soon as I feel that she's starting to push, I'll say, okay, wait, now let's concentrate on the gold line. That's the abdominal one. You have to keep that one as flat as you can. So you really, the idea of just putting in the probe and letting the patient work on their own doesn't really work. You've got to really be motivating them and seeing what's happening at the same time in terms of their contraction. Okay, so let's go on. So now what I'd like to do is I'd like to work on her strength. Okay, so she, she's starting to contract well, but she's still having problems. When she's even in her yoga class, she still has trouble when she changes some position. So what I want to do is I want to teach her to be able to do a strong contraction during those times that she's having trouble. So if she says, well, it's every time, I do the downward dog, I seem to have problems, I can feel that I'm leaking, but then I'll say, well, what you have to do is contract your pelvic floor prior to doing it and hold that contraction the whole time. So you have to train her up to that. So we have to get her strength. So here she's contracting. With the strength, I like to do a 5-10. So it's 5 seconds contraction, 10-second relaxation. So I'll train her on that to say, okay, this is great. And as her strength is improving, then I will I'll lift the line and say, let's try a little bit harder. Now, if I lift the line and her abdominals start to overwork, then I know that it's too much. So I have my eye on the abdominals. A good abdominal activity right now is about this much. That's great, okay? But if she tries too hard and her abdominals go up too much, then I'll say, okay, don't try as hard and try to just concentrate on the pelvic floor. Try to pull the probe inside. So I use it, like, as I said, an intracavity vaginal probe. Okay, great. So once she's done that, then usually this is what happens is that they are able, so you'll have them do also a urinary diary, and you'll have them mark down, like, what are your difficult events? When do you leak the most? And some patients don't feel it. So that's a situation that you have to deal with differently. But for the patients who feel, okay, I know every time I do this activity, I leak. I know every time I get out of the car, I leak. I know every time I cough, I sneeze. So usually what happens is they're able to get enough strength to use that. It's called the NAC, which is an internationally recognized term for tight perineal closure prior to an activity. So they'll know that, okay, I leak when I cough, so before coughing, I'll squeeze, and then I'll cough, and then I'll let go. So it's usually, they're usually able to work on that quite well. So strength is important for that. But what's difficult for a lot of patients is at the end of the day when they have fatigue, or else when they go for long walks and they feel that they leak when they're doing a prolonged activity. So in this case, you have to work on endurance. So working on endurance is where, as we did in the last lab, this is what I would work with her now between the 4th and the 6th treatments, is, okay, we know you can go up to 140. Now I'd like you to contract up to just the 60. So go ahead. Okay, you're on the rest cycle. Okay, so let's hold it there though. Let's hold it for a little bit of time. Okay, so keep on holding that line, keep on holding that line, keep on holding that line. And now we're working submaximally, and we're working on your endurance fibers. And this is the muscle that will kick in, you know, when you go for your long walk. So you have to be able to train these slower twitch fibers in order to be able to hold for longer periods of time and then relax. So this, again, is the way that we can do this, is that we can use this actually in a way to evaluate. So we mentioned how we can evaluate, train, educate, and do the exercise prescription. So often I'll do this evaluation when she's ready to start with endurance. I'll say, okay, show me a max. So go ahead, max, max, max. Don't worry about the work rest cycle, and release. Okay, so her max went off the screen. So here, Geva's just fixing the sensitivity so we know what the real max is. Okay, max, max, max. Good. So her max was 600, and then release. So now what we're going to work on, I'm sorry, I'm looking at the wrong screen. Which one is? Yeah, sorry, the A. So her max was over 800. So what we'll do is we'll work up over 400. So go ahead, lift up. Squeeze and hold over 400, and we're going to see how many seconds you're able to hold there before it starts to waver. So then I can look at my timer at the top at 6:03. Okay, she's able to hold that submax pretty good, pretty well. Okay, she's doing a good job. And then, oh, she's starting to waver now. Okay, down. So we see that she had like about 8 seconds before she started to waver. So this is going to tell me that she's able to hold a 50% maximum contraction for 8 seconds. So this can be an evaluation, and you can use that as an outcome measure and say that she, you know, you can't, you know, her 100% contraction might change from day to day in terms of how many microvolts that you see, but being able to do a 50% of that for a certain period of time, then you can actually use that as an outcome measure. So my goal is for her to be able to hold that for 60 seconds. So I see that she's only at 8 seconds. So for me, she does not have enough endurance in her muscle. So that's a way you can evaluate it. But you can also use that as your exercise prescription. So I know that she'll see on the screen, wow, I can only hold it 8 seconds. So when I'm training, I'm going to train 8 seconds. And then the next time she comes in and she's able to hold it longer, okay, great. Now when you train, you're going to train submaximal, but now you can train for 12 seconds. And we will build you up gradually. And eventually you should be able to hold that submaximal contraction for 60 seconds. So this is a way of educating her on how things work. You can also do the training that way. So when you're doing the training, as she's training with you with the machine, then she's understanding and feeling what it feels like. And, you know, like we were saying last time, a lot of patients say, oh, I wish I had one of these at home. Well, what I'll often do at this point is she'll say, well, how will I know I'm holding it? You know, so I'll say, well, okay, look at the wall and let's have you do it. So she looks at the wall instead of looking at the screen. She holds that contraction as long as she can. And then let's go, and then I freeze the screen. And then I say, look, this is what you did. You're able to hold 50. You can feel what it feels like. You didn't even look at the screen, and you could see that that's what you were doing. So that's how we can train them to really understand. So it's really a good way to train them and to educate them on what they have to do. Okay, so the other thing, okay, so we talked about coughing. So that's the strength contraction, lifting up the baby. You need good strength to go against the pressures of the intra-abdominal cavity. Endurance is more for long term. You know, you have a few sneezes, or you're walking for a long time and you start to leak later. So it's an endurance. So what I'll get the patient to do. So some patients might be having trouble when they run. So what I'll get them to do is hold a half level contraction when you start your run. and hold it for 60 seconds, or how many seconds they can hold it, and then do it again. And at every, every time you go off the sidewalk, then you're going to remember, contract your muscle for 60 seconds. And then they do it several times during their run, and then eventually it will kick in when they need it. So this is how the training works, is that the brain will eventually say, we need to use this muscle now. And so it will bring it in, and it will become reprogrammed. Okay, so then she'll say, very often my patient will say, okay, well, that's fine. Now I can do my yoga moves. I can, cough, but I'm still having trouble during the sneeze, because when I sneeze, I just don't have time to contract my muscles. So then we're going to work on speed. So you'll have you squeeze quick and let go, squeeze quick and let go, squeeze quick and let go, squeeze quick and let go. So eventually what I would like her to be able to do is to do 10 of these in 10 seconds. So I'd like her to be able to do 1 per second. And so this way she's recruiting and finding her muscle quickly. So let's try that. We'll go 1, let go, 2, let go, 3, let go, 4, 5, 6, 7, 8, 9, 10. Okay, so we're trying to get her to do 10 of them in 10 seconds. So this is one way of training for that type of activity where she needs to find that muscle quickly. Okay, good. All right, so she's done that. So now, okay, so we started no biofeedback. Then we went into biofeedback, just letting her know the difference between abdominals and pelvic floor. Then we started to train strength, speed, and endurance. And now we want to add on to working a little bit more functionally. So I want her to work her pelvic floor and her abdominals at the same time. So this is the one we demonstrated last time too, and this would be pertinent for this patient. So what you would have her do is, okay, first squeeze the pelvic floor. So bring up the left side, pelvic floor. Okay, now lift up your leg. So that would be, you're using the abdominals. So bring up the other one. Okay, and I'm going to resist that leg from going down. So hold tight. So the abdominals will go right up. The abdominals will go right up. So the gold one. So the right will go right up. That's right. Hold, hold, hold. Now we're going to let the leg down. Drop the leg down, but keep the pelvic floor up. Drop the leg down, but keep the pelvic floor up. That's it. That's good. Okay, keep the pelvic floor up. And now let go. So sort of teaching her to dissociate between the two, and to use the pelvic floor as a knack, as a locking mechanism. So this is a very functional way to work it. And I do this in supine with my patients, but it can also be done in standing. So the thing is that if you do this in standing, you need the type of probe that will stay in. So like sort of that probe that I had shown you, that's kind of triangular. And then you can do activities in standing, but really realize that there's so much crosstalk in standing. You're probably better off, the way I work, and I know a lot of therapists don't work that way, but it depends on your own practice. But I like to make sure in supine during biofeedback that nothing else is working and it's only the pelvic floor, so she can zone in on it. If I do the probe in standing, which I do sometimes just to motivate the patient and try things, I know that trace that I'm seeing in standing is probably influenced by the abdominals, the glutes, and everything else. So if she's trying really, really hard and contracting everything, her screen will go up and she'll think she's doing a good pelvic floor contraction. So what I suggest if you do this type of activity in standing is that you first have her just stand there, actually supported with her arms on, arms supported on a table, so she doesn't have to use too much extraneous muscles, and then just have her squeeze the pelvic floor and see the differential in that case. And then have her squeeze the pelvic floor and then lift one leg. But then you'll see it go right up, but you don't know if you're getting pelvic floor or crosstalk. So that's the caveat of working in standing with biofeedback. But it can be done. Okay, and so when she's in her advanced training, then I start to use templates. Okay, so templates would be where I have her follow a grid. So I think you might have one there. Yeah, so this might be a hard one, but what you can do, okay, there you go. Okay, contract and try to follow in the gray line. So he's got a contraction, hold the gray line, hold it, hold it. And what you can do, if it's too difficult, then you can just change the sensitivity so that it makes it a little bit easier to do. And then that way, it's more of a control thing. So that will help them to find the activity. So you get them to follow up. But there's different templates you can have. You can have up and down. You can have triangular. But this one would be like one of the more advanced ones where you can say, okay, let's really see. So here you can see examples of the different templates that you would be able to use. So I would often use something like a pattern 1. And then I might even try a pattern 5, you know, and then that way I've got a nice quick one down, and it's all got to do with control. So that makes it a lot more fun for them and for me. And so that way it sort of, you know, changes up the training a little bit. But very often, once you're up to templates, and if they get to be that good, then in that case, it's good to just get them off the table, forget the biofeedback, and start doing functional activities where they can feel the contraction. So this is another thing that I use biofeedback for, is to make sure they feel it. So let's just put it on a line graph again, Geva. Okay, so let's have you, okay, so contract your muscle to, say, just over the goal line. Okay, so the pelvic floor, contract that one just over the goal line. Hold it, hold it, hold it. Okay, keep on holding it. Okay, now when you release, I want you to think of what it feels like. Release the muscle, release, down. Good. Okay, so feel the difference between the two. Now I'd like you to do it again, and don't look at the screen. Okay, so squeeze up to the line. Okay, so now she's up and she's not looking at the screen. And then I'm going to keep on telling you when to contract, but when you release, I want you to be able to tell me if you really feel that your muscle lets go and let go. Okay, so then you get them to feel, what's that sensation? It's like a softening of the activity. So then when I get them in standing, I'll get them to do squeeze the pelvic floor, then lift their leg or do a different activity. When they finish the activity, relax the pelvic floor. Did you feel the pelvic floor relax? If they did not feel it relax, it's because they probably lost it already. They lost the contraction. So I want them to always be aware of whether or not it's contracting. And really, that's what you want to train, is their awareness of the muscles. So this is why often in standing, I just forget the machine and get them to go with what they feel. And does it feel like when you released, when you were with the biofeedback? So they have a visual of what it looked like, and the release, what it feels like, and they know, oh no, I lost my muscle. So this is one way of training. Okay, so I think that's it for this patient. I think what we'll do is we'll go back to my presentation. Can we do that?
Yep, of course. 1 second.
Okay, so let's just go back just to make sure we have that. Okay, so we've gone over this slide, and here we go. These are my goals. Okay, so the treatment 1 and 2, educate manual techniques. I do the stimulation exercises. Then as she gets better, then I added on this bar graph and the 2-channel line graph together to really see the difference between abdominal and pelvic floor activity. And I use that to help prescribe the exercises. I wanted you to keep in mind that the first few weeks of strength gain are generally due to increased neuromuscular recruitment. Skeletal muscles have a threshold for increases in this neural adaptation, but additional increases in strength can still be gained through muscle hypertrophy. So what this means is that when you're starting to train your patient, especially with the pelvic floor, because it's a muscle that people don't really know, is at first you're just helping them to gain their ability to recruit that muscle from the brain. Okay, so that's really what you're doing at first. And with the biofeedback, that goes a little bit more quickly because they have the visual as well. And sometimes you can do it with auditory. But then you can continue with the biofeedback even once you've recruited maximally, because the more that you work the muscle, the more you can gain the muscle strength. For patients with urinary incontinence, motor planning and timing of the contraction must also be trained. So like I said, we're not only interested in strength, we're interested in how they can plan to find the muscle and time it properly with their activities. And eventually we want to create that automatic response to increases in intra-abdominal pressure. So this is where, as the treatment went on, I was still doing education manual techniques. I stopped doing the stim because I didn't have enough time to do stim, biofeedback, and everything else, and all of the functional applications we started to do. So you can do functional applications with or without biofeedback, and that's where, I mean, what are the activities that are a problem? Let's practice those. Okay, so that's that for this patient. So the next patient is a 26-year-old woman who's married. She's a teacher and she has pain during sexual intercourse. She went to the gynecologist. She's actually seen 5 gynecologists and everything was negative. And one of the gynecologists finally said, why don't you try physiotherapy? And she was avoiding all forms of sexual intimacy, meaning she didn't even want to kiss her partner because she was worried that that might lead to potential intercourse and failure and pain. So she was avoiding everything altogether. So when I did her physical examination, I noticed that she had increased tone of the pelvic floor musculature. So what that means is that if I try to stretch the muscle, it's really tight and it's really increased in tone. So that's at rest. When I do palpation, which is any pressures on the pelvis, she had protective reactions. So you can see that there's a fear element going on as well. The vaginal introitus, the opening in the vagina, had a really smaller diameter because of the fact that the muscles are so tight. So I don't know if you can still see me, but I'm showing on this is that when the muscle contracts, it closes the vaginal diameter. So she has, actually a smaller opening at the vagina, which causes more pressure and more pain. She had decreased contractility because the muscle being so tight, it's not able to contract because it's already contracted. And then she also had decreased post-contractile relaxation. When she did manage to generate a contraction, she didn't relax her muscle enough. So this is the sort of the opposite training that we're doing with this type of patient. My goals are to decrease pain during sexual intercourse, to decrease her avoidance behavior, to desensitize the vaginal vestibule, to increase comfort at the vaginal entrance, to decrease protective reactions, to decrease her hypertonicity and overactivity of the pelvic floor, and to increase the comfortable diameter at the introitus. So, I mean, this is me as a physiotherapist, but I'm working in an interdisciplinary way, possibly with a psychologist or sex therapist and her gynecologist as well. So for our first two treatments, I don't usually put them on biofeedback right away. She already has a little bit of fear. She remembers that, being touched there hurt, and so she's nervous, and so having some apparatus sometimes is not really that encouraging. So the first couple of treatments, I'll be doing a lot of educating and teaching her that if we do learn to relax this muscle, then it will be more comfortable to have intercourse. Your natural response when you have pain is to tighten. We want to go against that natural response. Instead of saying, ouch, that's going to hurt, you say, oh, I'd better relax my muscle so it does not hurt. So we have to change her thought processes and change her response to pain and the thought of pain and the fear of the pain. So this has all got to do with, all of the pain science that there's so much research on right now. So we do a lot of that with our patient. Desensitizing, so I'm going to desensitize the area, meaning just touching on the outside and maybe just having her, take a small plastic tampon and then slide it between the labia so she feels, different sensations are not necessarily painful and dangerous. So we can do some insertion techniques, which I'll talk to you about a little bit later. But these insertion techniques can begin right away with something as small as a tampon or a finger. So once she's sort of desensitized a little bit and ready for more, then I might try the biofeedback. So again, education, manual techniques, insertion techniques. The biofeedback, if I'm using the probe, that's actually an insertion device on its own. So just getting the probe in can be an exercise on its own. So I'll have her contract, relax, and then I'll try to put the probe in, contract, relax, put the probe in a little bit more, and gently try to make her relaxed enough to be able to accommodate the probe. You can also do biofeedback, surface biofeedback for these patients, but I tend to think that since I want to do insertion techniques anyway, I usually, get two things done at once by using the probe as an insertion device and also using it for the relaxation of the muscle. So again, we can just try this on a demo, is we would do general relaxation. So for the first treatment, I would have the probe inside and I would have her do some general relaxation. And then I'd also look at what's called the post-contractile relaxation. So Geva, you can put that back on again. I'll just show you just how I would train with my patient. So that would be the 3rd to the 6th, and then 6th to the 8th, we'll be doing some speed contractions.
Okay, my screen is showing.
Okay. All right. So let me see if I can find you. Okay, there you are. Okay, good. So in this case, I would not put the abdominal probe on. I would just have the pelvic floor probe. Perfect. Okay. So let's say that you're, actually maybe you can put your 0 line. What I would do in this case is see, okay, that's her relaxation. I want to bring that 0 line up higher so that I can see more. So you want to be able to see more of her relaxation come in. So if you could set that up. So yeah, there we go. Good. Okay. Okay, so, just training, like basically I would say, okay, now I'd just like you to relax, just let your pelvis drop. Okay, we're just going to take our time here just to relax your muscle. You know that if your muscle's more relaxed, then it'll be easier to have intercourse because your muscle, when it's tight, it closes the vagina. So just try to relax and just take it down and just breathe in. Okay, so take a nice deep breath in and breathe out. So then, like we did in the last one, this is what I would work on with her. I would say, oh, try to find what it is that makes her relax more. And I'll notice that when I'm talking to her, it'll go higher if she's talking back to me. But if I say, just, you can relax, close your eyes if you like. If you don't want to, you don't have to. Just try to relax as much as you can. Find your pelvic floor and drop it, drop your pelvis. Okay, so for some patients that works. For others, it's squeeze tight, 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 and relax. So try to squeeze now, squeeze your pelvic floor and release. And sometimes you'll see that her relaxation will be more after a contraction. So it all depends on the patient. So I'll often sort of do a mix of both. I'll do, okay, now just do like just a light squeeze. Find your pelvic floor, just find it enough to squeeze it a bit, and now relax it. Okay, and let it drop. Okay, so the other thing you'll do is contract, relax. And then the other one is also with the breathing. The breathing in general will relax her, okay, for sure. But also by getting her to breathe and try to do, so I would have taught her how to do diaphragmatic breathing. So she would breathe and let her tummy expand. And as she breathes and lets her tummy expand, then I tell her, okay, if your tummy's going to expand, let's let the pelvic floor expand as well. So there's a whole training on breathing into the pelvic floor that we do. And then you can adapt that with the biofeedback. Okay, take a deep breath into the pelvic floor. You know how I taught you when you breathe in, it helps to relax the pelvic floor. Let the pelvic floor drop as you breathe in. So then we would work on that. Okay, that's good. Now, other things, I would still probably work on, the 5-10 contraction just to get her to feel what it's like to contract, relax, because when she's in, having intimacy with her partner, she has to be able to find that muscle and relax it. So she has to know what that muscle is. So she has to be able to know what the muscle feels like when it's contracted. So I would do, that's exactly what I would do, would be the mountain exercise. So what I'd like you to do is feel your muscle. So let's form a mountain. So climb a little bit more, climb a little bit more, climb up to the top, hold, and then go down slowly, gradually, and all the way down. So when you have intercourse, what happens is your muscle probably goes into the top of the mountain because, you remember how much it hurt and your body wants to protect you from that pain. So instead, what I'd like you to do is when you have intercourse, try to relax your muscle. Okay, so try to find your muscle and relax it. And if you find that you're about to have penetration and you feel your muscles tight, now you know what it feels like. What does it feel like when your muscle is tight? What does it feel like when it's loose? If you feel it's tight, then you just tap your partner on the shoulder and say, wait 1 minute or 1 second, and then you'll find your muscle and relax it. Okay, now you can continue. So there has to be communication with the couple in terms of, he has to go more slowly in order to allow her to relax her muscle, because if there's no communication and it hurts and she doesn't want to tell him and he doesn't even know and he's continuing, her muscle's just going to get tighter and she'll have more pain. So there has to be this communication. So you have to often, let the woman, and this is work that she might have to do with her sex therapist or her psychologist, is have her really affirm herself and say, yes, okay, I am aroused. Yes, I do love you, but this is a little bit painful. So let's just stop for a second. I'm going to squeeze and relax, and now you can continue. So there's that whole communication piece that has to go on. But if she can see it on the biofeedback and understand how her body's really responding, she can realize that she has control over this. She's control over the muscle. The muscle wants to be tight, but she's able to relax it. So it's very affirming for them to be able to understand how well they can actually do. So I would work on that. So I might work on, if I did the speed practice with her, so if you can squeeze and let go, a lot of patients who have hypertonicity, you'll notice when they let go, the let go is not fast. So squeeze, go ahead, squeeze, and then just sort of let go a little bit slower. And this is exactly what we see, an extra, yeah. So very often your patients who have hypertonicity or overactivity, when they try to squeeze, let go, this is what happens. So you have to teach them, your muscle didn't quite let go. Let's try to let go a little bit more quickly. And then you'll get them to do, instead of 10 in 10 seconds, okay, you're only going to do 3, but they're coming down all the way to the bottom so they can understand, okay, my muscle was not quite relaxed. I felt like it was relaxed, but okay, now I can just breathe a little bit more and relax it more. So this is one way you can do that type of relaxation training. So that's in the speed contraction. Okay, so I think that gives you a good idea. I think we can go back to my slides. I only have a couple more slides left, and then if anybody has any questions, I'll be happy to answer them. All right, so just to recap again with this dyspareunia patient. So we started off with the first the first treatment, not doing the biofeedback, and then afterwards we incorporated it into general relaxation, but also relaxing specifically the pelvic floor. So she could see that general relaxation will decrease the activity in the pelvic floor, but also by finding the muscle and relaxing it on her own, that will help her to have control of the muscle and be able to relax when she needs to relax the muscle. Some of these patients with hypertonicity, they might even have the muscle that's so tight that they'll have pain even when they're not having intercourse, just by the tension in the muscle that they might have. Then the speed contractions are really important to work with these patients so that they can see really, are they able to relax quickly their muscle. So I just wanted to talk a bit more about the insertion. I'm not selling these basics because there's all kinds of dilators that you can get on the internet. Yeah, working with a patient who has abstained from intercourse for a long time, and I usually use 3 months. I usually get them to work with dilators to insert objects of progressive width so that they can eventually feel that, okay, I can put this in, so I could probably have intercourse without pain, because she learns how to put in a dilator while relaxing her muscle when she's not in the the arousal and intimate situation with her partner, which could be more complicated to relax. So if she learns how to relax when she's on her own with the dilator, she'll say, okay, I can put in a number 4. So yeah, I could probably have intercourse. It's just that I have to be just as relaxed. So it gives them a lot of confidence, and it builds them up physically and emotionally for being able to have intercourse again. And sometimes they'll still have some pain in some certain areas. So we do different types of desensitization where we'll find the painful spot, and we can use electrical stimulation, or we can use manual techniques in order to help to desensitize. Okay, so those are the 2 case histories. I just wanted to say about troubleshooting. So sometimes you're doing your training and suddenly you'll get sudden peaks. Okay, so that could just be interference. It could be they moved and they got a peak. So you'll always look at your reference electrode to make sure that it's put on well and it's sticking on well, and that will give you fewer of these, unwanted peaks sometimes during training. If the abdominal trace is too high, we saw that in the demo, is that we just bring the trace down, but keep your eye on it. If the patient's not able to decrease the pelvic floor trace during relaxation, you have to use all the techniques that you can to try to bring it down. But sometimes you have to just stop the treatment because they get more upset that they can't relax, that it's counterproductive. If the vaginal probe slips out during contractions because they're pushing instead of contracting, and if the patient uses the glutes during their contraction, you get them to not try so hard. Usually when they use the compensating muscles, it's because they're trying too hard. Just bring in the skin, do a small movement. And if the patient has pain during the pelvic floor contraction, it could be that they could have a urinary tract infection, or they could have too much hypertonicity and it's causing too much pressure on all of the structures when they contract, so they might be inhibiting. So that's that. So in conclusion, biofeedback is useful and interesting tool for pelvic floor rehab, especially because the pelvic floor muscles are hidden, and you can train different muscle fibers, different muscle activities, and different functional applications. And we use it for evaluation to a certain extent. Like I said before at the first webinar, your absolute value is not what you're looking for. You're looking for how they're working over time. But your absolute peak amplitude is really not something you can compare from one day to the next. You can compare it within the same session, though, so that would work. And we use it for exercise prescription. So that's it.
Thank you so much. We are okay with time.
So if there's any questions.
I want to invite anyone who has any questions to ask them right now in the question box on the panel on your usually the right of your screen. We do have one question already, asking, besides leg lift in standing, do you have any other functional activity ideas?
Yes, absolutely. So leg lifting and standing is just an example of how you can use the abdominals. So the functional activities you want to work on are anything that's going to increase your intra-abdominal pressure or use the abdominal musculature, because as soon as the abdominals work, it pushes on the whole cavity and causes pressure over the bladder. So, even if they're doing, because you use your abdominals to stabilize. So sometimes I'll just have them standing and doing biceps curls with weights. Sometimes I'll have them pushing an object. Sometimes I'll have them lifting their baby. So anything that where you're actually doing any abdominal work. I do also do abdominal work in supine, where they squeeze the pelvic floor, do a little bit of a crunch, relax, and then release the pelvic floor. Squeeze the pelvic floor, do a little bit of a crunch, relax, you know. So once they've learned how to do that in supine, then I'll get them to do abdominal exercises in standing. So I'll get them to do crunches, like squeeze the pelvic floor and crunch in standing. Then I'll get them to do planks. So anything that really increases, it gets you to use your abdominal muscle. That would be what you want to train the pelvic floor to be able to contract first, do the activity, finish the activity, and relax the pelvic floor after.
Excellent, thank you. That is it for our questions.
Okay, great. So it was my pleasure teaching you guys, and I hope it helped.
Thank you very, very much, Claudia, and thank you everyone who attended. You will receive an email after this with links to the recordings of both webinars, last week's and this week. And we hope to see you soon in upcoming webinars as well. Thanks once again. Thank you very, very much, Claudia.
Okay, my pleasure. Bye, everybody.
Goodbye, everyone.